Hello and welcome. It's great to be here with you. Thank you so much for joining. My name is Dr. Jim Boonyaratanakornkit, but please, you can just call me Jim. I'm an infectious disease specialist at the Fred Hutch Cancer Center. And my main work when I'm not seeing patients is in the lab, developing medications for respiratory viral infections. Before I dive into my topic, I just wanted to invite you, if you wanted, and are willing and able to turn on your screen so that we can all see each other and greet each other. And if you don't want to, that's okay too, but I just wanted to offer that opportunity. It's always good to see each other, even though we're not physically together in person, but we can be together virtually. So if you'd like, feel free to turn on your screen. If not, it's okay. And I'll jump right in to our topic of this morning. Okay, I'm gonna share my screen. Great, I hope you can see this. And again, my topic today is on the latest in COVID-19. We're gonna learn about COVID vaccines, boosters, and the impact of COVID on transplant patients. I hope this will be interactive. You can type in questions in the chat as we go, and I'll try to address them. And hopefully we'll have 10 minutes at the end for discussion and questions. So let's dive in. We're gonna start by reflecting back over the last few years. Then we're gonna try to answer 5 questions. What's my risk? What can I do to mitigate the risk? Okay, I've been exposed, now what? All right, I have COVID-19. What are my options? And finally, how will things look post-COVID? So this presentation is being recorded so it can be made available to you and others. And this is our land acknowledgement. Our campus sits on the traditional land of the Duwamish people. We honor with gratitude the land and the Duwamish tribe. Actually pictured here is also our COVID Clinical Research Center, where many landmark studies on COVID prevention and treatment were conducted. This building used to house the Obliteride, which is happening live in August to raise support for cancer and infectious disease research. So let's take a breath and look back into the past a bit. We're going all the way back to December 2019. And I remember personally reading reports of a cluster of cases of infections in Wuhan, China, caused by a novel coronavirus. And in January, the CDC started to screen passengers at airports from Wuhan. But by January 20th, the first case was confirmed in the United States. And that was in our state of Washington. In February, the FDA authorized the first diagnostic PCR test, which unfortunately did have problems early on, but were eventually fixed. And then the WHO announced the name COVID-19. In March, the WHO declared a pandemic, and states in the United States began shutting down. The first human trial of a COVID-19 vaccine also enrolled the first patient, which is really remarkable. In April, the CDC recommended widespread masking, and Operation Warp Speed was launched to produce a vaccine ASAP. In May, the FDA authorized the first COVID-19 antiviral. Another sad milestone was that the unemployment rate hit 15%. And in December, after much anticipation, finally, the first COVID-19 vaccines were authorized by the FDA. However, this next year, 2021, was characterized by what I would call the rise of the variants. In June 2021, the Delta variant became dominant. And in December, Omicron comes along. And the FDA also authorizes another antiviral called Paxlovid. So now we're in 2022. The Postal Service starts distributing home antigen tests. And in May, we reach a tragic milestone of 1 million deaths. So a lot has happened. Let's talk about risk. What's my risk? So this is important. That's why I just put this line on its own slide. The mortality rate with COVID-19 after stem cell transplant is 15 to 30%. Does mortality depend on whether you received an autologous or allogeneic transplant? So far, the data suggests no. The mortality rate is similar. So what is associated with mortality then? Studies have found an association with increased age, male sex, infection within the first year of transplant, having lymphoma, having moderate or severe immunodeficiency, or having decreased performance status. And there are 3 general periods of risk. In the pre-transplant state, patients can be immunocompromised due to their underlying disease. They can have poor responses to vaccination. And an infection with COVID could delay their transplant and lead to progression of their disease. In the early post-transplant period, so during the first 100 days after transplant, patients are also vulnerable. They can be immunocompromised as a result of their conditioning and chemotherapy regimens. And vaccinations are generally delayed during this period because patients probably would not respond very well. And later in the post-transplant period, after 100 days, patients can still be at risk if they're immunocompromised from graft versus host disease, or if they have disease relapse. They also might have increased exposures to COVID as they re-enter the community and have more contact with other people. And in fact, most infections by respiratory viruses occur during this period. So what can I do to mitigate my risk? I think of this like a multi-layered cake, and this one happens to be extremely colorful. You want to have multiple layers of protection. So this is the first key point. The benefits of mask wearing are well established. When should you wear a mask? One thing that you can do is check the level of COVID-19 in the community. And the CDC has an online tool for this, and the link is here. So I put in King County when I had to submit these slides back in June, and we were at a medium level of transmission. I checked again this morning, and unfortunately, now we are at a high level of transmission. So the CDC is suggesting that we wear a mask indoors whenever we are out in public. The other layer of protection is vaccines. We have 3 main types of vaccines available. We have 2 mRNA vaccines that are highly effective. The primary series involves 2 doses, and we'll talk about boosters later. There are rare, extremely rare cases of myocarditis, heart inflammation related to these vaccines. Then there's an adenovirus vaccine, basically another virus called an adenovirus, which is generally benign in humans, is used to stimulate the immune response against COVID. The efficacy is a bit lower at 71% compared to the mRNA vaccines. And there are rare cases of clots related to this vaccine. And then more recently, the FDA has approved a protein-based vaccine, which is formulated as a nanoparticle, meaning a lot of the proteins are stuck together to stimulate the immune response. And this vaccine has high effectiveness, but there are also rare cases of heart inflammation with this vaccine too. What about transplant patients and vaccines? So our general recommendation is to start the COVID vaccination series as soon as 3 months after transplant to give time for the immune response to the immune system to recover so that it can mount a response. The first 2 shots are the primary vaccinations. Then there is the 3rd dose, which is a booster that can be given 3 months after the 2nd dose. And then there's the 4th dose, which is another booster that can be given 4 months after the 3rd dose. And interestingly, the risk with these boosters for developing myocarditis is lower compared to the 2nd dose of the vaccine. So if you didn't develop myocarditis after the 2nd dose, the chances is that you will not develop these complications or side effects with your booster shots. The jury is still out whether additional boosters will be needed to protect from the newer variants. The FDA just a few weeks ago recommended the development of variant-specific vaccines. And this colorful graph that you can see at the bottom right shows the variants identified in our virology lab. Again, these slides were made in June, over a month ago, and you can see that BA.5 at the bottom right corner was at a very low level back then. I looked again this morning, and it is now over halfway up this graph, and it's over 60% of all viruses in Washington state. Another layer of protection is the monoclonal antibodies. Evusheld is one drug product that is approved by the FDA and provides 77% reduction in symptomatic COVID-19, and it can provide protection for up to 6 months with a single dose. It's associated with rare cases of heart disease, and those patients generally had pre-existing heart conditions though. Patients at higher risk for serious infections with COVID are eligible for this medication, including transplant and CAR T-cell recipients. All right, so you've been exposed. What can you do now? Well, testing is important. We have access now to free home antigen testing. The recommendation is to test if you are symptomatic. And if you're asymptomatic, you can test 5 days after exposure to check if you caught COVID. And you can also test before going to an indoor gathering, especially if high-risk patients might be present, to avoid potentially exposing them. Now, the sensitivity of these home tests are good, but they are not perfect. They are around 70% sensitive, so they could miss about a third of cases. But you can retest in a day or two, though. That can improve the sensitivity to over 80%. The PCR test, though, is the gold standard. And in general, if you have been exposed, the recommendation is to isolate for at least 5 days and potentially longer if you're still having fevers. And you should mask for at least 7 days around other people who have not been exposed to you. And you should discuss with your medical provider and also watch for warning signs of worsening infection, like trouble breathing, chest pain, or persistently high fevers, confusion, or if you have a home oxygen monitor, decreased oxygen saturation. These are all warning signs to discuss with your medical providers, or potentially just even consider going to an emergency room. So what about post-exposure prophylaxis? So these are medications that can be taken after an exposure to prevent infection. Currently, there are none available, unfortunately. However, there is an ongoing study at the Fred Hutch to see if an antiviral called Molniperavir can be used for this purpose. Okay, this is a photo from the film The Matrix. I have COVID-19. What are my options? Which pill do you choose? The greatest benefit for treatment is with early administration within 5 to 7 days of symptoms. Paxlovid is an oral antiviral that is associated with an almost 90% reduction in progression to severe COVID-19. An important thing to note about Paxlovid is there is a potential for drug-drug interactions. For instance, with cyclosporin, which patients might take for the prevention of graft versus host disease. In general, one of our pharmacists does help review all the medications to make sure it is safe to take. Another antiviral is Molniperavir. This one did not perform as well as Paxlovid, but did reduce progression to severe COVID-19 by 30%. It should be avoided in pregnancy given the potential risk for toxicity to the fetus. And then bebtelovimab is a monoclonal antibody that is effective against the Omicron variants. It is given as a single infusion. The efficacy is not clear for this drug though. And then the fourth option is remdesivir. This is an intravenous antiviral that is associated with an 87% reduction in progression to severe COVID and can be given at any time. And importantly, it can be given to help patients who are in the hospital with severe COVID-19. And we can also use steroids, another antibody called tocilizumab, or a medication called baricitinib that works on the immune system and can help with severe COVID. So what about transplant patients? Transplant patients are vulnerable because their immune systems are weakened, and they can shed virus for longer periods of time. They can have repeated infections too, and resistance can emerge in the virus. Dr. Larry Corey from our center wrote this important piece in the New England Journal of Medicine talking about these issues. So we do need more research, more medications made available to determine if transplant patients could benefit from longer treatment courses, combination therapy, or new cell-based therapies that target the virus. So we are near the end of this session. I wanted to touch on how will things look post-COVID. So we're going to try to look into the future. You are all probably familiar with the phenomenon of long COVID. So it's thought that 10 to 20% of patients experience symptoms for weeks to months, including fatigue, neurocognitive difficulties, anxiety, depression, lingering cough, chest discomfort. These are more likely to occur if the illness is severe. And the current strategies to help patients with this is to provide support, to allow rest, recovery, better sleep hygiene, rehab, physical therapy, mental health services. And there's also a potential that there's an autoimmune component to this phenomenon too. And we have a clinical trial at the Fred Hutch ongoing to study this. And if there's people who have had this or questions about this, please feel free to put that in the chat, or we'll have time at the end to discuss too. So will we ever be done with COVID? I believe this virus will reach an endemic state where it will circulate in a stable and predictable fashion. This has not happened yet because of the variants. Seasonal cold viruses like influenza, rhinovirus, those are endemic. They're predictable, they're stable. But even these viruses, they all still have the potential to cause severe disease in vulnerable patients. And that risk will remain even when COVID-19 becomes pandemic. So this is a graph of hospitalizations for COVID in Washington. Again, these graphs were all made in June. I checked again this morning, and that dot on the right-hand side of the graph continues to make a steady rise. And so we are seeing increasing levels of hospitalization of COVID-19 patients in Washington. But to end, I do want to again reflect and say a few words of encouragement. We got this. And over the last 2.5 years, it has been remarkable the progress we have made. We have developed 4 vaccines and 4 antivirals. That is almost unheard of in the field of medicine. We know masking is effective. We have rapid home testing available. We can and need to do this for other respiratory viruses and viruses that afflict transplant patients, and for which we still have no vaccines or effective treatments. And again, another plug for the Obliterate, that's the photo on the top right, which is occurring in August to raise support for cancer and infectious disease research.